And I can't hide, 'cause my pains are keeping me up at night.
The information that we share today is from our own personal experiences and does not constitute medical advice. We do not endorse any products or services. Any said products or services mentioned on this podcast may not be suitable for you or your condition. Please consult with your physician if you have medical questions as it may pertain to your condition.
Hi everyone, welcome back to Take a Pain Check. I'm so excited to introduce this week's guest, Dr. Joost Schwartz. Dr. Joost is an MD, PhD, and he is board certified pediatrician, immunologist, and rheumatologist as of 2008. His research focuses on comparative effectiveness and safety of drugs, treatment strategies, and e-health in juvenile idiopathic arthritis. Additionally, he is a co-principal investigator for the Can Do project, a large translational project for the innovative precision medicine strategies in JIA. Hi, Dr. Schwartz.
Yeah, Natasha, thank you for having me.
Thank you for coming on. It's a pleasure to have you on today. Can you start off with a brief introduction about yourself? I know I gave a very long introduction.
Yeah, so I'm indeed a pediatric rheumatologist and a clinical researcher in Utrecht, the Netherlands. So it's a small field, pediatric rheumatology. So we collaborate a lot with multiple countries, and we have this special connection with Canada now. So we're really excited about the project of Can Do, which we do think will change the whole field of JIA.
I totally agree. I actually did a summer internship with Can Do, and that's how I kind of heard about your name and how you're really involved and heavily involved with the research. And it was really interesting to hear that Canada Netherlands has such a good connection in terms of rheumatology and how they're working together and collaborating. Because as a JIA patient, you do want to hear different perspectives on what other countries are doing and how we can all work together. So I kind of wanted to start off by asking you, where does your interest in rheumatology actually come from? Like, why did you decide to become a pediatric rheumatologist?
So when I was in training for a pediatrician, and the first one to ask me was, in fact, my chief in Amsterdam, who said, I think you would make a fine pediatric rheumatologist. And that was the first thing that planted in my head, you can say, as an idea. And in fact, I didn't know too much about the field at that moment, and he said you should go work a week in Utrecht and find out if that would be something that you would like. I was amazed by the patients and by the team in Utrecht, and I thought, okay, this is a field that is in a lot of change now. There are a lot of new therapies and opportunities coming, and I think we can probably really mean something. Not to be disrespectful to the past, but to be honest, we didn't have a lot of therapies when we were, for example, in the 70s. You couldn't do much, so you only had corticosteroids, or we didn't even have methotrexate at the time. So when the biologicals came around, and that was just a few years before I started my fellowship, the whole field changed, and then I think we made a huge progress, but still there are a lot of things that need to be resolved. That's why we did start Can Do. So in fact, we see a lot of, we have to treat everybody the same way. I have to start methotrexate in polyarticular patients first, although we already know that multiple patients will not benefit from that. A lot of patients will not tolerate it also. Yeah. So you would really want to know, okay, who is the person that will do fine with methotrexate only and will tolerate it as well. Don't waste your 3 months observation on the methotrexate in the other patients. So that's, to reduce that burden, that would make a huge difference, we think. And but now there are a lot of dynamics going on there's a difference in cost. So this is why Can Do also put in the health economy to make a real good case about why should you start. So in some patients you should start right away with the biological, and this is what we are now aiming at personalized medicine, looking at which individual patient do we have, what are the clinical characteristics, what are the biomarkers in the blood, for example. So these are a hint to a certain drug that could be very useful in such a patient. And all these data that we are gathering need to be analyzed in the end, and then you would probably have much better prediction of risks of failure or the response rates will go up for sure, and the burden of waiting in vein will go down,
Yeah.
and thereby the pain and chronic pain, chronic fatigue, and a lot of things that need to be addressed right away as well.
So your, I guess, passion for rheumatology, or what kind of sparked it, was during your training years, and when it was like someone told you that it could be a potential good option, like they see you kind of fit in that category, is what you were saying. And you brought up personalized medicine, which I find very interesting, because I think as a JIA patient, we want to not kind of get on every single medication and not know that if it's not going to work. Or personalized medicine is so important. And I really find that what UCAN is doing is really good for JA patients. Like, I wish I had something like this 5 years ago when I was diagnosed, not just, oh, let's try prednisone, let's try methotrexate, let's try biologics, and none of it works, right?
So everything, and the trial and error, if you're really, if you're really honest, it's a bit of that. And of course, we have a guess that this drug might work for 70%, but you would like it to have it 90 or 95% effective. And of course, we will never get to the 100 at the moment, but I don't think 70% effectiveness is a very good rate. And if the intolerance to a drug will come up to maybe even 50% sometimes, that's not a good drug for a lot of patients then. And so of course patient preference could be different. Some people do really hate needles, and so there are differences in patient, and we get a larger arsenal, so we have more choices now in drugs. But the problem there is also that with all these new drugs coming, physicians tend to stick to the drugs they have most experience with. I'm not an exception though, but so the drugs that came in first normally will stay the first prescribed drugs for years or decades even, because we feel safe and we know what effectiveness is, and we don't know too much about the new kids on the block. But if you don't, you will never get experience then, right? So now there is this new drug also approved in Europe, which is an oral drug. It's a small molecule drug. It's tofacitinib, and we are not very experienced in it. And but you can, if you say I'm not very experienced in it, it's just been approved in June. I don't think I can use the same excuse in 5 years' time. I don't think that isn't right? I cannot say, okay, it's already for 5 years, it's been approved for JIA, but still I never used it. But now you don't really know which patient to start this drug. It's a new drug, and with UCAN you will probably have patients that say, okay, this route is exactly, this drug is blocking that route. This would be the drug for that patient, right? So that could be a whole game changer. This is what we believe.
Yeah, and I think that game change is what we all of the patients need, because as someone who was diagnosed 5 years ago, like, things weren't like that. And even like you mentioned, some of the drugs like methotrexate, a lot of people didn't even know about it a while back. And I even heard that sometimes like a long time ago, biologics weren't a thing. So a lot of older patients have so much joint damage because it wasn't a thing, right? So medical advances in technology and what's kind of coming to the forefront and coming forward is so important that people make use of what's happening. And I'm really glad that UCAN exists, and it's definitely going to make a very good change for a lot of patients. And I'm very excited to see how that is. I wish I had that, but it's okay. Got to see how it's going to impact other patients and the future.
Yes, and I do think that there are a lot of domains that need to be addressed still. And so I'm talking about effectiveness and response, but these are mainly physician domains that we often want the active joints to be gone. So a physician could be very happy if there's no active joint anymore because they feel safe. There will probably be no damage. There's no active joint. But it could still be that the patient is in a lot of pain. Could be that the patient has a lot of fatigue still. Or, for example, there's morning stiffness. The patient cannot play on a soccer field. So the personal treatment goals that patients have could be completely different from what you as a physician are aiming at. And so in this app, we will try to build in a lot of these things as well. So the patient preferences, one item. So what do you prefer? And that could, I mean, some people say 3 times a day, a tablet, that's for me, it won't work. I know my day, I'll always miss the afternoon one, right? So it could indeed, I hate needles. You don't, even if it's once monthly, I will never be able to do that. I mean, those are preferences that you need to take into account.
It's really nice to see that patient voices are even considered in this case. People, I guess, like, you don't really have a voice and an opinion, and it's like whatever drug is given, and if it's in that form, you have to take it, and your preference is not heard. And it's hard on a patient to even not be able to voice their opinion because either they're too scared, it's not an option. And so it's good to see that this is something that will change.
So there is a gap in knowledge between the physician and the patient, right? So we are going to the congresses, we're specialized in it, and so we're doing it for years. And then you come along with your child, and you have JA, and you didn't even know it was JA, so you know maybe close to nothing about it. Mm-hmm. And then this person says, okay, you need to take this drug. Wow, well, let's do it. I mean, yeah, well, it sounds like a good plan. But do we really have? Do we really say these are all the options? These are all approved drugs for JIA. For your kind of JIA, these are the approved drugs. And for efficacy, these are the results from literature. These are the side effects that you may encounter. If you have a certain second disease, for example, you have asthma or whatever, maybe it's not such a good idea to take this drug. Or in your family, there are people with this kind of disease, maybe you should refrain from taking that drug. So there are a lot of things that might alter choices, probably. Yeah. Now you get most of the time, and I'm not an exception, so I'm not saying that I'm any better, but no. So we all have a limited time amount, and you want to start, to be honest, as soon as possible. And in the Netherlands, we are lucky enough to be able to start directly after the visit. So if we have methotrexate, okay, probably that will be the same in Canada. But even if that fails and you need a biological, we don't need to discuss it with our insurance companies in the Netherlands yet, at least. Wow. So we can do that, and we can start it right away. The pharmacy will give it with the patient directly, but still, I don't have 2 hours to explain all the options. Yeah. But that's an app could probably. I mean, if you buy a headset, for example, you're looking at reviews, and you're comparing stuff that you even didn't know exists either, right? So it's the noise cancelling and the Bluetooth. Now, so these are things that you know, but there are also like 5 variables that you didn't think of, and you maybe 3 of them are not of importance to you. You could do that for drugs as well. So this is, I mean, it's more important than a headset. And you want, okay, I want a Google review on this medication. What are my options really? And let me help choose the right drug. And that's something that we envision, at least for the You Can Do app, that the biomarker and the clinical characteristics will probably say, okay, these are the 3 drugs that would be suitable best for this patient. But now it's the patient to choose from these 3 drugs or whatever amount of drugs come out of the alcohol.
And I think as a patient, we understand that physicians don't have 2 hours to sit and explain everything to us, but also having a platform where education awareness about these drugs and a reliable resources out there is very important, because I know most of the time patients just resort to the internet where not all the information is reliable, right? So
No, that's indeed a problem. But there are also, I mean, there are also a lot of things we don't know.
yeah.
So if a patient asks, so I had this patient that asked me, could I stop the medication? Everybody could stop medication. I mean, that's for, I mean, if they throw it at the plants, I don't, I mean, in their living room, I can prescribe whatever I want, but if people don't take it, so, but I rather discuss it with my, so I'm already happy about that question. So can I, so let's discuss about, so what would ideally be the case? Maybe what we know is maybe taper the drugs, so maybe dosage lower, or maybe the frequency, the interval you prolong. But if some person says, no, I really want to stop now. I had this patient that 3 months was inactive and said, I want to stop now. I said, okay, I don't know, maybe it can. I mean, if you really want to stop, let's just stop and see what happens.
Oh.
So you have to listen to the, I mean, I don't have a reason to say it's impossible. If I know that after 9 months of inactive disease, it's as good to stop or taper the drugs than at 15 months, for example. So it doesn't really matter if you prolong beyond the 9 months, but to take it to 3 months, nobody studied that. We never do it. But yeah, if this patient says, I'm completely done with the needs, I want to stop it. Okay, let's just see what happens. And so still there. If you don't know as a physician, also you have to be honest. I just can't say I don't know what's in the bag for you then. But there's only one way to know what will happen. It's just to do what you suggest then.
I mean, I definitely say it's important to be able to have that conversation with your physician to even get to that step where you can say that. Yeah. So it's important to definitely be comfortable, and your patient has been comfortable in terms of not knowing what the future is. I mean, at least you're being honest and they're being honest in how you feel. Yeah. So there's nothing you can really do about it. So you have bilateral grade 4 knee arthrosis yourself. Can you explain a little bit about what that is and how this kind of affects your daily life and when your symptoms developed?
As a kid, I had osteochondritis dissecans. It's your cartilage in my knees were messed up, so they broke a chip down in my right knee, and then my knee was locked, and then in fact we found out it was messed up with the bone and the cartilage. And I had a first operation, and then I had 6 months with crutches and splints, and I wasn't able to sport for many years. I wasn't allowed to jump or run, and I had a second operation after half a year, and it failed to regrow really. And after I was outgrown at 18, my orthopedic surgeon said, okay, now you're fully grown, and it's okay, it's fine again, and you can run. But I completely forgot how to run, and I don't know if it's the same for you in your sleep, but in my sleep I didn't even run anymore, and I could jump in my so you completely internalized it. It's not that I really had to learn how to run, but it was funny too. There was a lot of blocking in my head. And but eventually, okay, it was good. I did a lot of sports, and when I was studying, I did a lot of rowing competition. And but after many years, I was playing volleyball. I had this swollen knee, and then apparently I had grade 4 arthrosis, which means that your cartilage is gone, and it was in both knees. And I didn't know that. That was because of the osteochondritis I had as a child, and they never told me. Nobody told me, okay, you should probably be really wary of something might happen with your knee or get a follow-up X-ray or so I might have made the wrong decision by playing volleyball many years, because that's not a very good sport for your knee. So well, it's the way it is, but so I had to quit all sports really, and that's something that, as a physician, I take with me. That if people ask me, am I allowed to do sports? I'm always on the side of yes, you should do sports, and it will not harm your joints. We know that will not be damaged, but it's also something that I make probably more X-rays than my colleagues, just to be sure that there's no damage happening. I don't do it every year though, but I'm always a bit wary of something might have. I might not have seen that a subclinical disease or something that. So maybe that's something that is coming from my personal life as well, that I take with me. So let's just be on the safe side there. But but I know the impact of not being able to run. If you had a fight as a kid, I knew I couldn't run away, right? So you had to talk you out of it, so there are a lot of implications of not being able to run or sport.
I think your personal experiences have kind of shaped how you are as a physician in a way that you're a bit more mindful about when you do talk to a patient, or in terms of like even movement, like you mentioned sports and stuff, and if kids come in. Do you think your personal experiences have kind of helped you?
Yeah, certainly. I think, I mean, it forms you also, right? So it isn't fun if you can't do. I mean, I love skating, for example, and so I could do all that. But it's the way it is. It happened, and I don't think I'm a worse person. I think it made me grow even more, probably.
How do you alleviate the pain that you have on a daily basis? What do you do?
So I'm just cycling and hiking. That's the things that I do. And if I have a lot of pain, I take an NSAID. So I have another. So they normally consider arthrosis grade 4 to be very painful. So I went to the orthopedic surgeon. I don't have a lot of pain still, and then they said, okay, then you don't apply for surgery either, because that's something. So I'd say, so I'm lucky there. I don't have a lot of pain, but I have a very soon it will swell, and then okay, this was too much, right?
Yeah, I think when you get into that routine, which is not the best thing to get into, the routine of knowing how your pain cycle works. And when you get to know that, then you know ways to help yourself. I think that's very helpful. Yeah,
but I when I had to stop volleyball, I was pretty emotional over it. So I mean, you really lose something you like, and but I mean, probably that's life about it. And I'm not a kid anymore, so I learned to live with it. But it's not a lot of fun. I liked volleyball a lot, and I like my team as well. So,
yeah. I mean, I used to play tennis, and then I got arthritis, and then I had to stop. And I really enjoyed playing tennis. And when I knew that it wasn't worth being in so much pain to, play tennis, I mean, now I've tried to play, and it's so much better because it's been 5 years since I was diagnosed. So my joints feel better. But at that time, I understand how sad it can be to just, like, you're so into something and you have to stop because of your health.
But you are able to do it now again.
I am, but I don't do it. I don't have time anymore. But if I were to, the other day I did for a bit with my cousins, and I did not feel any pain, and it felt really great to come back to it and know that it's fine now. I just don't have time for it in general anymore. But
that's okay, right? You don't have to do it, but if you're able to do it,
it feels so much better knowing. Exactly.
Yes.
And I wanted to talk about what your specialties are, and you specialize in immunology as well, am I right?
Yeah, but that's common in the Netherlands. So there are no pediatric rheumatologists who are not also specialized in immune deficiencies.
Oh, okay.
So it's not a unique thing. It's just a Dutch thing, I think. We're all trained to be rheumatologists as well as immunologists. Yeah.
Oh, that's so interesting because I don't think anyone here would completely know that it's normal and in the Netherlands, but it's interesting.
Yeah. So I mean, and there are also countries in which you are a pediatric rheumatologist as well as a nephrologist, which is the kidney.
Yeah.
Which I think it's to me that sounds strange. So I can imagine that this sounds strange as well. But so we're used to it. We feel it's normal. Kids that are born with a lack of immunity, that's also something that we're specialized in. Although I do have to admit that one colleague of mine is much more specialized in it than I am. But yeah, it's the immune system, and it can go either way, right? It can go if you have too much or immune. If you have a very reactive immune system or active immune system, it might lead to autoimmunity. And that's more my specialty than the immune deficiency. But indeed, we do see a lot of patients also when I'm on a call with immune deficiency.
How do you evaluate success as a rheumatologist? How does your kind of evaluation scale work in terms of success? I know a lot of rheumatologists think differently in terms of success, and I'd love to hear what your success is.
So this was not a JAA patient, but it was a lupus patient I saw this morning, and the nephrologist just came out of his door. It was coincidental, but and then this patient with lupus came out of my office, and I said to him, "This is her. You remember she was weeks on the ICU, and then she came walking. She had all her hair back." And he was really amazed. And I mean, that's something that's so rewarding. That's success, I think, that you have a very ill patient or a patient in a lot of pain, and for JIA, for example. So this is something that was really striking to me this morning. But for JIA, it's the same. So they might come in a wheelchair, and they can do anything anymore. And after that depends on which medication. I mean, methotrexate is very slow, which is a very uneasy, to be honest. So you have to take like 2 or 3 months to wait for the results. But biologicals might work with after 2 injections sometimes, that people really feel much better. And the morning sickness is gone, and they are running. I had this patient also, it was half a year ago, and she had a lot of pain and difficulty, couldn't run or jump, and now everything is fine. And then if it's so it's so well controlled, the disease, and the symptoms are gone, then you wonder, how long do you still need these drugs, right? And I think that's a good thing, that you are at some point you and the parent and the patient are realizing, maybe I don't need it anymore. And some people might try them by themselves. I always say upfront when I start, so that we will try to stop it. And but let's do that with each other, right? Because I honestly think that it's better to do it together with a certain scheme, and then we can learn from it also as a community. So what's the best tapering scheme? We call it tapering or spacing. If you lower the dose, or you have a interval that you prolong. Mm-hmm. So they always ask, in fact, if they're really good. So okay, let's start the countdown. And I normally say, okay, let's start the countdown. Now you're completely inactive. Now we are counting for 9 months. So we'll stay on this course still for 9 months. So that one patient I just talked to you about earlier said, okay, it's 3 months, but I'm really done with the syringes, and I'm done with the needles. Okay, so that's a different. Normally we go for 9 months, and then we'll taper. It takes another 6 months, and I know what are. So you have flare rates. It could, but you also have a 25% chance after 1.5 years that you don't need the medication. So you won't have. I can't tell you who you are. I can't tell you, are you the one that doesn't need the medication, and is in the 25% at 18 months that's still inactive without the medication, or are you the one that had a flare? And if you have a flare, so the disease comes back after a year without medication, maybe it's not so bad either, right? You didn't have a medication for a year. Well, I mean, that might have been worthwhile. I think the real disappointment is when you stop the medication or you're tapering it, and it comes right back after a few weeks. I mean, that's really disappointing. And I mean, but I cannot predict it as yet. But that's something that also you can do. We are looking to how to withdraw the medication, and we try to predict the risk of a flare.
Wow, that's exactly what I need. Prediction.
That's exactly what. And then still, I think it's up to the patient to decide. Let me take that risk. Okay, you say I have a 85% chance of flare. I don't mind. I want to. But maybe some people would say, well, this is my exam year. I don't think this is the right moment. But I have 85%.
It's hard to make that decision alone. And that's what's good to definitely talk to your doctor about it as well. But at the end of the day, it's sort of like a prediction, like you mentioned, and you don't really know, but you take that risk to see. Like I know, like methotrexate, you mentioned it works very slowly. I was on methotrexate 4 years ago, and it didn't work for me, but I'm on it now. And I actually went on methotrexate 3 times.
Okay.
With different drugs. First time methotrexate alone didn't work. Methotrexate with biologic didn't work. Now methotrexate with sulfasalazine and Plaquenil, it's working. So it's definitely just a combination of just drugs to see what works. And as a patient, it's so frustrating. Like, I don't enjoy needles, yet I still have them. And I've heard so many stories of different patients saying how like the certain color of methotrexate makes them nauseous.
I know, yeah.
But
so it's yellow in the Netherlands, and
same here. I've heard so many stories, and I felt nauseous once. I'd say I actually like threw up, which is not the best ideal thing to do, but it happens. I mean, you get used to it as a patient when you take so many. It's just a normal part of life, unfortunately. We have a sponsorship with UCAN Can Do, and our audience has a bit of a knowledge as to what is being done in this trial. And you mentioned the goals of the study, sort of to have more of a personalized medicine plan and treatment for each patient. How do you think overall this will improve the outcomes for children with arthritis?
We have a lot of ideas, to be honest, but also even on the implementation of it. So don't waste too much time in getting the effective treatment. That's, I think, one of the major things. So we want to understand JIA, and we want to have a kind of a new phenotyping, so that you really say, okay, there's a very distinct phenotype of JIA. Now we're doing, I don't know if you are realizing, but we have these subtypes of JIA, and it is from the 90s still. We're counting joints and say, okay, this is a polyarticular patient because there are 5 joints involved. After if it's in the first 6 months, it's 5 joints, you're polyarticular. If it's 5 joints in 7 months, and before that was 4, you're an extended oligo, so you're a different category. It doesn't make a lot of sense, to be honest. So that's different. And the other thing is that we're wanting to, what medication do you want to start? Which is most effective for this individual, and I'm certain that we will get there, and not just say, okay, you're having JIA as a whole group. Just first start methotrexate, wait 3 months, and we'll see who didn't benefit, and then okay, let's try B. Let's try drug B now, and let's see who will benefit from that. And we don't even know that maybe we don't have the luxury of waiting. Maybe if you're waiting 6 months to get the right medication, maybe you had the window of opportunity for another medication to work. Maybe that's gone. Maybe now you don't have the same disease anymore. Maybe now it's becoming refractory because she missed the first 6 months to treat the patient, right? We don't know that, to be honest, but it makes sense to. Apart from that, it makes a lot of sense, of course, to have the right medication as soon as possible, just to reduce the burden of the disease for the patient.
Yeah, it really does. So the collaboration between Netherlands and Canada is very strong, and even like given kind of the healthcare systems, what are your thoughts on the treatment approaches between these two countries? I know you work with some Canadian researchers and stuff like that. So what have you seen and observed in terms of the difference in healthcare?
I think there are more similarities than differences, to be honest. I think between Canada and the Netherlands, we sent our queen baby there, right, in the World War II, and I do think that, so we feel very connected to Canada, and I think there are not a lot of differences in how we treat our patients or in how we engage our patients. There might be a few differences in how insurances are regulated. There's of course there's a large difference in how large your country is. You have multiple time zones, and maybe the access to a tertiary center will be a long drive. I mean, we have a very small country. You can drive through our country in 3 hours, so it's completely different. So there are differences, but I don't think there are a lot of differences. So, the distance in Canada is one of the things that, for example, in our You Can Do studies, we needed to have stable biomarkers that, if you use the right tube, you can ship and for hours and hours. So you don't have. In the Netherlands, you can just drive, and 1.5 hours later, you're in Utrecht. We are in the middle of the country, but that's not the case in Canada. And it's a good thing, even because if you think a bit further and you think biomarkers might be interesting to know which drug do you use, maybe also to when to withdraw a drug. Can you now withdraw a drug because you're so inactive? Is the blood telling the same? Are you really inactive? Will you be likely successful in withdrawing the drug? That could be taken at home, that sample, right? And this is something that we're looking into now also, that maybe people can just do it themselves and sending it via the mail. And I will tell you next time you come, or maybe on the phone, I will tell you, oh, wow, it's really looking good, just stop the medication, or I'm sorry to tell you, but it doesn't do too well. I really have to continue the medication. Yeah, wow. That's what the microsampling is about now. What we're looking at, and the JIA at home is something that we're also trying to implicate in this collaboration with Canada. That people do assess themselves. We did need to do that now in the Corona period, right? That people weren't sometimes not allowed to come to the hospital. Well, then you have to probably learn how to assess your joints yourself, and we already did a small study in that. And if patients said, I'm completely fine, and they had to do that 2 weeks before they visited us, they were always right. There was only one patient that didn't notice that there was some minor problem in the jaw joint, but that didn't need any alteration of the medication. So all these people that said, I'm completely fine, they probably didn't need to come, really, right? Yeah. So they're so good in self-assessment. I think that's something that we're heading at also.
And if you think about it, like even during the pandemic, we always have to self-assess our symptoms and kind of go through the surveys and kind of assess what we're going through. So I think even like with that practice, people should be more, I guess, used to now the process of self-assessing in the healthcare field. It's definitely a lot of these advancements are being even more noticed because of the pandemic, I'd say. That's
true. And I think that now a lot of logistics of the hospital are burdened on the patient. I mean, that's their burden. I have outpatient clinic 2 or 3 times a week, and but if you say, but I can't come, then or we say, okay, let's have you come back in 3 months' time, and you say, okay, that's fine. It's 3 months time. You don't discuss about it. And then 2 months, after 2 months, you have a lot of pain. And after 3 months, you come to the doctor, it's just fine. And then you walk away, and a week later, you're still in a lot of pain. So we are deciding when you have to come. It might not necessarily be a moment that you wanted to show your joints because.
Yeah. I think that's the fear. Sometimes the fear is that sometimes the way everyone evaluates pain is on a different scale. And if I think the pain is too much, maybe my too much is different from your too much. And then on top of that, sometimes people self-diagnose themselves and they don't, it's very like a hit or miss sometimes with patients and how they feel. Like you were mentioning, like in some instances, people are able to determine how they're feeling, but sometimes they can get convinced by other things to kind of confirm what they're going through, if that makes sense.
Yeah, and I think that if somebody says I have pain or I am in pain, you are in pain. There's no discussion about it. Nobody.
Yeah.
Sometimes people say they don't take me seriously. I don't know why you should take somebody seriously who says pain. What's the fun of having pain?
Yeah.
Right? So that's completely senseless. But I don't think that the logistics of the hospital is very rough system, and you just say, okay, now we make the appointment ahead, and you have to come then and then. But it might be completely the wrong moment for you as a patient. And with the self-assessment, you can have a kind of a continuous assessment or a continuum of care. You can show the graphs if you like to do that. I mean, you don't have to, but if you say, okay, well, you're just at this point, you're meeting me now. I mean, I'm really good, but you had to see me a week ago. I wasn't unable to play soccer, or they had to drag me off the field, for example. And I mean, that's what JA sometimes does, right?
Yeah, I think in the end, it's really important just to communicate with your physician, no matter what it is, and to be honest with yourself and with your physician. Because internally, if you're not honest, then you're kind of hurting yourself inside in terms of your joints and what could potentially happen. So it's very important to just be honest with yourself and your physician. And in terms of some advice that I wanted to get from you, just so we can let our audience know, I have 2 questions. What advice would you give to youth who want to get involved in research and kind of give their patient voice?
So, in fact, in UK Can Do, of course, we have Cassian Friends, and we have the JA Patient Association in our hospital. We do have a co-worker who is a patient representative, and he is Casper Schoenmaker. He also developed a top 10 priority in research projects. So it's JLA, James Lind Alliance. He asked many patients and many parents, what do you think should be researched for JIA? So you can just start that yourself. So this is what he did. You can just email physicians. You should ask your physicians, can I be part of research? We really like people to be active in our research and think about it, and just tell people, what do you think that need to be addressed? Diet is also a thing that is of highly interest of patients. So what can I do with my diet, or did I do anything wrong with my diet that I have JA now? We don't grasp any of it, to be honest. Maybe it's important, but at the moment we have no idea. So there's no reason to say to patients, just stop eating your strawberries or chocolate or whatever. We have no idea, right? So there's no answer there, but probably there needs to be research in that field as well at some time.
Yeah, I agree. There definitely does need to be research in that field, and hopefully it'll be up and coming. What is one piece of advice you would give to those who are interested in starting a career in the field of medicine and are interested in rheumatology?
Yeah, so I was thinking, some people really always knew that they want to become a doctor, and some people find out later. In fact, I was one of the latter categories, and when you're studying medicine and you feel that, and it's a very broad range, you can make a change. And after, if you become a physician, you never ask yourself, was this a day worthwhile? Did I do anything useful? And that's there are of course more professions than being a doctor, but there are also professions that you might probably wonder, did I really help myself, or did I help the world, for example? And I've never have to ask that question myself. So I think that's wonderful, because even it doesn't matter how long your day was, you did something well, right? So that feels very good. I mean, that's something very rewarding for me. The field of rheumatology is very dynamic. It's for pediatric rheumatology, it's a very small field, which I think I like, because you learn to collaborate. You need to collaborate. It's you have congresses international, and you will soon meet all these international colleagues, and you will start to know them. So I've been in this pediatric rheumatology field now for 16 years, and I know most of them, I believe. So when I'm at a congress, I know very many of them, and they're really friendly people. That's something you choose. So if you're in medicine, you choose a field that you feel comfortable in, and in which you can be yourself. And it's not always possible to. So when you're an intern, you're in different fields, and you sometimes feel, okay, this is not my place. I have to play a role here, really. And I would advise not to find a specialty in which you have to play a role, because you have to do that the rest of your life then. And that's pretty hard. I think that's probably, that makes you very burnout prone probably to do that. So I would, where can you be yourself, and will you be accepted as such? I think that's something. And of course, what is of interest? So the main thing in rheumatology is dynamic. It's evolving. There are multiple therapies. We're doing a much better job every year. We can help more people. You have, for pediatric rheumatology, you have to like parents. And of course, I do that, but you hear sometimes from interns that they have difficulty communicating with parents. So you shouldn't go into pediatrics then, right?
Yeah. And I think like you mentioned, there's always like something that kind of interests you when it gets to that point, and then being interested in talking to parents, children, and I guess where the best health happens and stuff like that. So like for me as well, like I do aspire to also be a pediatric rheumatologist, and that's because of my own personal experiences. And I think, and definitely like getting into that and knowing that this is what I've been through, this is what I want to do, because I've seen so many rheumatologists, and I definitely do see how it is evolving with you can do and everything. Like I just find it really fascinating. And so I think when youth find what they're interested in, like you mentioned, I was never even interested in medicine ever as a child. And it was only till when I got joint injections actually where I got really excited. I mean, not excited to the fact where I was going to be in so much pain, but intrigued by why they were taking my blood and saliva and putting them in a bank, and actually analyzing the blood and saliva samples and what it could do. And that's where I got interested. So I think a lot of youth, depending on where they're at in their life, like that's kind of the things that they are surrounded by is what kind of inspires them to do what they want to do, is what I'd say. So thank you so much, Dr. Joost, for coming on to the podcast today. I really had a great conversation with you. We talked about many things, like some of the project that you're working on, how that is kind of going to evolve the future of arthritis research and medicine and change things, and also what you do on a day-to-day basis and your interests. And I'm really excited for everyone to hear this episode, and everyone check out Dr. Joost's social media channels, everywhere that he's been featured, read about can do and what the future will be with this study, and like, comment, and subscribe. And I'll see everyone next week on Take a Pain Check. Bye.
Thank you, Natasha.
Thank
Bye.
you.
I can't hide, 'cause growing pains are keeping me